So, welcome to our webinar series on data and measurement in youth mental health. Before I introduce myself any further, just want to let you know that we don't have voice translation available, but we do have caption translation. And so if you do want translation in French, you can go to the bottom of your screen and hit the three buttons, and you will be able to get the French recording. And I'll just put this in French into the chat. So I'm Alyssa Frampton, and I'm the coordinator of the CIHR Catalyst Grant in Youth Mental Health, which is a pan-Canadian network and knowledge translation grant aiming to provide opportunities for the youth mental health community across Canada and through this webinar series globally to engage and network and share developments and build collaborations around data and measurement in youth mental health. So through this webinar series, we're really hoping to better understand the current and future landscape around data and measurement in youth mental health and what's happening, where are the gaps, how innovations are filling them, and also how we can move forward together. This could really range from issues such as integrated data collection, evaluation and service settings, novel or innovative data platforms and opportunities, and also learning health systems approaches. That's one of the topics we've already heard about in our series so far. We've also touched on why data and measurement matters. We've talked about the basics of what it means to have a learning health system, as I mentioned. We've talked about things that we might want to consider about when we're thinking about standardization. And today we're going to talk about ethics and responsible measurement in youth mental health. So if you want to learn more about the series, or if you want to watch those past webinars, you can follow our YouTube channel. You can find them on YouTube. I'll put the links in the chat in a little bit. And you can also find it on our website and learn more about the grant. I'll put that in the chat also in a little bit. And lastly, before I introduce you to our speaker for the day, I just want to let you know that you should use the Q&A function if you'd like, or use the chat, but also at the end, and I'll explain this again if you need at the end of the session, that you can use your raise hand function at the bottom of the screen, and I can turn your mic on, and you can use your mic to ask your question if you'd like to do that instead. So without further ado, Dr. Eran is the Canada Research Chair in Data Ethics and Associate Professor of Philosophy at McGill University. His work deals with the epistemic and ethical dimensions of data collection, data analysis, and data use in the sciences. He's contributed to the philosophy of measurement, an area within philosophy of science that deals with the concepts and problems involved in designing and operating measurement procedures. His current research projects concern the conceptual foundations of psychometrics, the governance of youth mental health data, and the ethical implications of AI-driven algorithms in healthcare. And so I'm going to pass it over to you, and we're really excited to learn more about responsible measurement in youth mental health care. Thank you, Eran.
Thank you very much, Alyssa, and thanks also to Jay for organizing this wonderful webinar series and inviting me to contribute, and to everyone attending today. It's a real privilege to be speaking to you as a philosopher. You probably don't get too many speakers who are philosophers, and I hope by the end of this talk you'll see why philosophy matters. If you're not already convinced, why philosophy matters to what you do. So like Alyssa said, the title of this talk is Responsible Measurement in Youth Mental Health. And it's the result of an ongoing project that I'm engaged in that explores the relationship between the ethics and epistemology of measuring mental health, especially in youth and young adults. Before I tell you more, I'd like to acknowledge that McGill University is situated on the traditional territory of the Kanien'kehá:ka, a place which has long served as a site of meeting and exchange amongst First Nations. I recognize and respect the Kanien'kehá:ka as the traditional custodians of the lands on which we meet today, and I encourage you who are attending to type in your own version of your own land acknowledgement in the chat. I also want to say that besides the acknowledging the land and the people who have made this their home, I also want to acknowledge the importance of First Nations principles of ownership, control, access, and possession of data, which is going to be very relevant for this talk. And of course, that includes mental health data. So those of you who haven't heard of OCAP principles, I encourage you to look that up. So what is this talk about? This talk tries to answer 4 main questions. And in the time I have, I can only answer them in a cursory manner. But I hope this will inspire you to think and research more. The first question is, what does it mean for young people to be engaged in mental health data collection and use? We keep saying that youth and young people should be engaged, should participate, should collaborate on data collection, on data governance, on the way data is used to make decisions in mental health care and in research, both biomedical research and health policy research. But what does it mean exactly for youth to be engaged in this, and how deeply should they be engaged? Should youth be engaged for that engagement to count as meaningful? Meaningful engagement is this kind of buzzword that we hear a lot. But what exactly does it mean in the specific case of data and mental health data? And moreover, what underpins normatively this kind of meaningful engagement? What is the source of ethical legitimacy of youth engagement in mental health data practices, data collection, data use? And what are some of the barriers for this kind of engagement? What's keeping mental health services and research in clinical psychology and psychiatry from fully realizing currently meaningful engagement of youth with mental health data? I'm interested in this as part of my broader interest in data ethics. As Elisa mentioned, I'm the Canada Researcher in data ethics. And data ethics, I understand it to be very broadly the study of the ethical dimensions of data collection, use, and governance in scientific research, healthcare, and policy. So it's not just big data. If you hear the term data ethics, don't confuse it with AI ethics. Data ethics includes portions of what falls under AI ethics, but it's quite a different focus. It includes the way questionnaires and surveys interact with the population that they're intended to study, and the ethical implications of those interactions, regardless of the size of data involved. And there are lots of different ethical concerns that fall into that study: privacy and consent, bias and unfairness, or health justice. Misinterpretation and misuse of test scores have been studied a lot. Stigma and discrimination, and I also mentioned data governance, such as OCAP principles. But today, I want to focus on a specific dimension of data ethics, which has to do with patient autonomy, with the choices that young people have when it comes to the sort of measurements we take. So imagine you're a young person, you're stepping into an integrated youth service center for the first time. And as part of the initial screening, a staff member asks you to fill out the patient health questionnaire, the PHQ-9, which I know that this group has already discussed in previous talks. Here you can see the first 5 items of that questionnaire. And that questionnaire is is one of the most commonly used tools for assessing symptom severity for depression. And now my question to you is, what do you get to choose? As that young person who's stepping into the Integrated Youth Service Center, do you get to choose whether your depression will be measured, whether you get to choose how the construct, in this case, depression, is being conceptualized? So is it conceptualized in terms of symptoms or in terms of function? Do you get to choose whether what the content of the items will be, or which instrument is going to be used, or how the data will be represented, such as numerically or qualitatively, or ordinally or cardinally, how items are worded, the specific testing and administration method, whether it will be self-reported or clinician-reported, whether it will be static or dynamic, and whether you get to choose how scores are calculated, how scored get assigned to responses, and how they get aggregated across items. And of course, the answers to all of these questions is no. In the vast majority of cases, the young person is not responsible, does not get to choose, does not have the autonomy to choose any of these aspects of data collection. But of course, if we hope to be a co-created, if we hope to have co-created youth-centered mental health services, at some point, at least some young people should participate in making these choices, and so do their service providers, clinicians, for example. Things don't end here. Besides choices about the way data is collected, there are also questions about how the data is interpreted and used. And here you can ask yourself, does the young person get to choose which scores count as better or worse, how scores are referenced, whether they're referenced to a norm or a criterion, what the thresholds are for clinical significance? For example, what score counts as mild or moderate or severe depression? What is the meaning of a change of score over time? What change of score counts as, say, recovery or remission? Which decisions are informed by which data? The kind of pathways that the data will inform, and whether other information is used, whether, for example, clinical judgment and patient preference will be used as part of the clinical intervention. And you can add broader questions about what will happen with the data, where it will be stored, who will own it, how patterns in large data sets will be discovered and used, if, for example, a machine learning algorithm ever runs on that data. And again, in most cases, for most purposes, young people do not participate in making these choices. The main thing I'm going to try to convince you of today, if you're not already convinced, is that taking youth engagement seriously means redistributing power and not just collecting testimony from young people. Of course, in some cases, young people are part of the focus groups that inform the construction of a measure, but that usually only happens once, and it doesn't happen typically at the site in which young people are in fact treated and interact with the service provider. Focus groups happen in kind of sterilized, abstracted research settings, and then these measures get imported into practice, usually with little to no change. So the youth and young people who are accessing healthcare services usually do not have any control over the content, let alone over all these other questions I just included. So what does exactly mean to redistribute power, to have youth really have influence on the way the data is collected, the way it's interpreted, and the way it's used? doing this, I'll argue, involves a fundamental rethinking about what data and measurement are, what the concepts of data and measurement are, and the institutions that surround data and measurement. And the idea of responsible measurement that I'll briefly present today has to do with a different way of understanding mental health measurement. Understanding mental health measurement as a social technology, that is, as a means of shaping society and individuals' place in it. In this case, the young person's place in society. So rather than thinking of measurement as primarily an epistemic practice and an activity of gathering knowledge, measurement under a responsible measurement approach becomes primarily a social technology, a way of intervening in society. And knowledge is a welcome benefit of that intervention, but is not the primary purpose of it. And this conception, I will argue, legitimizes young people to challenge mental health data practices in a deep way, which is, I think, what we need in order to improve young people's lives. Okay, so that's a lot to cover, and I want to signal in advance that my treatment of the topic can only be somewhat superficial in a short talk, but I want to at least inspire you to think about these topics seriously. This talk will have 3 parts. In the first part, I'll talk about barriers to youth engagement in data practices, what is currently keeping youth mental health services from realizing the potential of youth engagement in data practices. And after that, the second part will talk about responsible measurement. And finally, the third part will talk about something called ethical iterations, which is a particular way of going forward towards realizing the vision of responsible measurement. Okay, so how does a philosopher get to even think about all this? Philosophers are known to just be sitting in the library and reading all the time, aren't we? Are we just supposed to be thinking abstract thoughts? Well, I had the luck and the privilege of collaborating with several health outcome researchers and health system designers who introduced me to the world of integrated youth service centers, integrated youth services, specifically in British Columbia, and a network I'm sure you're all familiar with, the Foundry. And this particularly started when I started having conversations about measurement with Skye Barbic, who's the lead scientist at Foundry. And what I learned is that well-established measures are being used at Foundry for various purposes, like screening, like helping with diagnosis, like helping track progress. But these measures are measuring something different than what clients and clinicians care about. And our first goal when we started this back in 2019 was to try to have a conversation with clinicians about how to measure in the best way we can, given the current state of the field. For that objective, for that goal, we created a guidebook and a training program to help youth mental health clinicians make the most out of patient-reported measurement. This was our team. Besides me and Dr. Barbic, we had a wonderful team of project advisors and students who helped us write the guidebook and deliver so far 2 iterations of the training. The guidebook is titled Mobilizing Measurement into Care, and I'm happy to say that it's in the final stages of internal proofs, soon to be submitted for publication. So watch out for this new publication in your area. It's an 11-chapter non-technical guide made for clinicians, specifically at Integrated Youth Services, and it includes a non-technical intro to health outcome measures. What are they? How do they work? What's the theory behind them? But also, what's the ethics of measuring mental health with questionnaires at Integrated Youth Service Center? What's the purpose of measuring mental health? And how to select the right measures, how to interpret scores and integrate measurement into clinical practice in a way that is collaborative and co-created with young people. So this work was the first step towards really thinking collaboratively with clinicians, with young people, about how to measure mental health better. But the part of this work was realizing that there are lots of barriers, systematic barriers, that cannot be addressed simply by creating a training program for clinicians or young people. There are systematic barriers to the way researchers and funders and regulators think about mental health measurement that go far beyond the scope of this or that training program. One of them is that instruments are already fixed and standardized. The way questionnaires such as the PHQ-9 or the GAD-7 for anxiety or the K-10 for psychological distress, the way these instruments are created is in a very top-down way. There's a team of researchers that create and validate the measure, and then it becomes frozen. I asked DALL-E to create an image of a frozen questionnaire. These questionnaires can no longer be changed. They're fixed and standardized, and even the choice of which questionnaire to use is usually already set by the organization before the young person walks into the door. The choice of which measures are available is already very constrained. Moreover, instruments are not designed for a large part with or for young people specifically, and even the few that are only include the young person as part of that initial design stage. But then young people are shut off from any subsequent deliberation once the instrument is being used. The clinical pathways within an institution like Foundry and the thresholds for directing young people to say different levels of a step care model, those are already set by the organization. And moreover, clinical client power imbalances are very common. So differences in authority, in age, and education between the client and the clinician, and other power imbalances that have often to do with race or ethnicity or immigration status. They make it very unlikely that the young client will challenge any of the measurement practices that are being followed. And behind all that, there's an overall epistemic doctrine about measurement. What measurement is supposed to do is extract information from the young person. It's a one-way street. Measurement extracts information from the young person. The young person is a passive subject. In that regard, the young person is not different than a desk that you're interested in measuring the width of the desk. The desk is simply passive. In that what's called the metrological vision of measurement. Metrology is the science of measurement in physics and engineering. Psychometrics is in large part adopts that view of the measured subject as essentially passive. Well, one way to try to correct for that is to instill principles, deploy principles of learning health systems into youth integrated youth services, and that is, I think, overall a good thing. But there's a word of caution here, because for learning health systems to learn, they need comparable data based on common metrics. So the idea is that you get this data from applying whatever questionnaires you're using. You translate that data into some helpful knowledge that you wish to generate, and then you translate that knowledge to practice, and your practice helps you learn what data you may need in the next iteration. But data collection practice itself is also part of health practice. And often, even well-intentioned implementations of learning health systems end up with data collection practices that are still frozen. They still use the same questionnaire, the same items, the same wording, oftentimes because it's the funder or the regulator that requires the health service to do that. But as long as data collection practices aren't free to evolve, health systems will not fundamentally learn. What data collection practices need to do is to be free to evolve and reflect the priorities and values of the health service and the client population, in this case, the young people. So this is not a criticism of learning health systems as such, but a word of caution about how they're implemented. Depending on how they're implemented, they can be either an engine or a barrier to youth engagement in data practice. Okay, so now let's continue on to responsible measurement. What exactly do I mean by measuring responsibly? Of course, we all want to measure responsibly, and there are already a lot written on data governance and on principles of privacy and ownership of data. So what exactly is responsible? In what way is responsible measurement saying anything new? To make the point clear, I want to distinguish between two existing approaches to measurement and values, to the relationship between measurement and values that predate responsible measurement. So one approach is what I call knowledge first. And in this approach, first you measure and then you apply. First you measure, then you use the results to pursue some goal. This is very commonly the way we measure physical things. First, measure the width of my desk, and then I can decide whether the desk will fit in my room. First, this is also a kind of caricature, a picture of how physical illness and diagnosis works. So first I measure the patient's temperature, and then I take a scan, and then I decide what the diagnosis is, and then I decide what the treatment is. Of course, even in physical health, diagnosis is a much less linear and more complicated story. But the knowledge first approach takes the knowledge and values to be distinct. What I need to know is distinct from what I care about. First, I need to gather the information. Then, based on what I care about, I take some action. Then there's the mirror image of that approach, which I call values first, in which first you decide what you care about. So first, you decide what kind of intervention or kind of change you want you care about in the world, and then you design your measurement practice to promote these values. And in a moment, I'll give you an example of that as well. But what I want to say is that both of these processes are linear. They're linear in opposite directions, but neither of them is sufficiently flexible. Either approach would be too rigid on its own, and that's because they don't iterate. If I go from knowledge to application, or if I go from values back to the knowledge I need, and just stop there. If there's no iteration, if there's no revision, then I'll end up with a measurement practice that's too rigid. And this leads me back to the question of how deep youth engagement should be. How deep do ethical and social values, specifically, the ethical and social values of young people, how deep should they, how deeply should they influence and shape measurement practice? On the knowledge-first approach, we're back with PHQ-9. The practice is to simply gather information, and the values informing the measure are they're still there, but they're hidden. So if you look through the list of items, there's nothing there about what you intrinsically care about, but you have to read between the lines, and you have to learn a lot about where the questionnaire came from. I'm very lucky in that sense, because I'm speaking after Professor Nicola Byram already spoke in this series, so you know from her what complicated history the PHQ-9 has, how it was designed to minimize the time physicians spend with patient, and how they were designed to help pharmaceutical companies sell more antidepressants. So to know what values kind of underlie the PHQ-9, the PHQ-9 itself won't tell you that. You have to study and realize historically that the main values were had to do with minimizing cost, increasing efficiency, and increasing profits. On the other hand, on the values first approach, these kinds of measures are less common in mental health, but they're very common in some areas of economics, such as development economics. The Human Development Index is a great example. There you first decide what you care about, what counts as human development, such as long and healthy life, knowledge, and a decent standard of living. And then you put together an index that weighs these different dimensions in accordance with how you think they should be weighed. So data collection becomes importantly part of is shaped by your values to begin with. But there's a third way, and here I'm inspired by Leah McClymon's work on patient-centered measurement. Leah McClymon is a professor of philosophy at the University of South Carolina, and she says the coordination of health constructs with patient-reported measures must involve iterative contributions from patients. Patient involvement takes the form of a negotiation regarding values. So it's not a one-time thing. Give me your values and I'll tell you what the measure is, or measure and then do what you care about. It's an iterative, ongoing process in which both the knowledge and action are reshaped by each other. And a variety of stakeholders, including researchers, including clinicians and patients, have to continually negotiate their values in a way that shapes the understanding of what we need to measure. So the content of the construct itself is affected by value negotiation. And that's a stronger claim than just saying that human measurement is value-laden. The very content of the construct is shaped by values. And this leads to the broader idea of measurement as a social technology. We're used to thinking that we're just extracting information from patients. But if we follow social historian Ted Porter, measurement is, and numbers, they're meant to instill an ethic. They provide legitimacy for administrative actions. Think of funneling young people into care pathways, in large part because numbers provide standards against which people judge themselves. So numbers are not these neutral things that have this kind of scientific objectivity air to them. Numbers, especially when those numbers are generated from a questionnaire that you just answered with responses that involve reflecting on your own life, numbers have a normative dimension. Every act of measurement is also an intervention on individuals and on society. Filling out a questionnaire, you don't just provide information, you also absorb a lot of information about what depression is, about what counts as more or less of it, about what kind of expectations you should have about treatment, for example. And the very questions often enforce various norms, social norms and organizational norms. And if that's the case, then measurement should be evaluated primarily by its contribution to the achievement of some social and individual good, rather than just leave it to whichever powers to decide how measurement will influence individuals and society. Wouldn't it be better if we are explicit and intentional about the social and individual goods that we want from measurement, such as health, equity, autonomy, or efficiency? This is where responsible measurement comes in. Responsible measurement is a process that involves iterative co-stabilization of knowledge and values. It encompasses not just measure design and interpretation or data collection, but also data analysis, measurement-based decision and policy, and data governance. This notion of responsible measurement presupposes a pragmatist view of measurement. Like I said, measurement is not primarily about generating knowledge. Of course, measurement does generate knowledge, but measurement is about primarily affecting some social change. It is a kind of social technology. And this provides the ethical legitimacy for deep, meaningful youth engagement in measurement. Youth engagement in measurement becomes a means of shaping some part of society. That part of society that is being shaped by the integrated youth service that you've just accessed. And those changes, of course, could reverberate throughout families, communities that those service centers serve. So being measured and being active in shaping the measurement practice is a way for a young person to shape the society in which they live and their place in it. And that's a very different way of thinking about measurement. So before I conclude, I want to provide a glimpse of what it might look like to pursue this vision of responsible measurement. And I want to focus on what my student, Sebastian Rodriguez Duque, and Sky and me call ethical iterations. In a recent article published in the journal Measurement, we argue that there is no value-free fact of the matter as to whether and how well a questionnaire measures a psychological construct. This idea that we can think of validity and reliability completely independent of social and ethical values is simply a myth. Improving a measurement practice requires reflecting on ethical and social values. It's not just a consequence or an implication of measurement. It's part of measurement itself. The very content of what we measure and how well we measure it depends on our ethical and social values, not just the statistical properties of the measure. And what we propose is an iterative, circular process that we call ethical iterations, in which first, if we look at the top square, stakeholders, including clinicians and young people, reflect on the current values informing the theory and practice of measuring something like depression. So For the case of PHQ-9, they could ask themselves, which social values underlie the PHQ-9, and whose values are they? And like I said, this may require research into how the PHQ-9 was created, what data was used in validating it. Then, in the next step, we need to collect evidence on the consequences of measuring depression under current values. But this is not just an abstract kind of data collection. We have to collect it in action as part of the specific service that we're trying to provide. We have to ask, what do clients think about filling out the PHQ-9 at my service center? Is it measuring what our organization cares about, what our clinicians care about? This is something we've heard a lot about from Foundry clinicians who often want to practice strength-based and more kind of positive focused approaches, but all the items on the questionnaire are about negative consequences, negative symptoms. Next, we want to collect evidence on the values of the interested party. What do young people care about? What do their families care about? What do their communities care about? And how is that reflected in the questions we ask them? And then there's normative deliberation and value revision. How can we revise the values? Which values do we need to revise in order to align the values informing the measuring instruments and the measuring practices with the values of our stakeholders? And finally, and very, very importantly, the measures cannot be frozen. They have to be defrosted. We have to be able to modify the items we choose, the kind of referencing or interpretation we use with the scores, the weighting of various items and subscores within the total score. We have to have flexibility in the way we design measurement practice in order to align the practice with our values. So to conclude, what I've argued for is that we need to measure responsibly, and responsible measurement is an intervention on individuals and societies. It's not just a passive way of extracting data. Youth engagement in measurement is ultimately a means of shaping society and youth's place in it. I know this sounds quite grand and very very abstract, but it happens every time a young person fills out a questionnaire, or every time a young person and a clinician consult each other on the meaning of the responses a young person gives on the questionnaire. This is an intervention on that young person and on their on the clinician and the larger institution and community. And without a shift to responsible measurement, the ability of mental health systems to learn will ultimately be limited by the rigidity of measurement practice. If measurement practice stays rigid and top-down, driven by research that is not in situ, that is that takes place in some other context and imported into a clinical context, then our health systems will not be able to learn and be truly evidence-based in the way that is meaningful and relevant to the populations we serve. So participatory decision-making on measurement is crucial for youth to have real power at the organizational and system-wide levels. We often talk about having youth at the table, but we have to ask what the role is at the table. Is it merely to hear their testimony that they're there, or do they have real power in affecting change? Can they choose which measures are going to be used on them? Can they choose how the data will be interpreted and what decisions will be made about them based on this data? If so, then that's a step towards responsible measurement. And I want to end by just opening up two questions for discussion. I'm very curious to know, in your view, what constitutes meaningful youth engagement in mental health data collection and use? What is meaningful youth engagement in this way, in this context? I'm curious to know what you think, and I'm curious to know what you think needs to happen, what needs to change for us to get there, for youth engagement in data practices to be truly meaningful. So I want to thank you for your attention and time, and I look forward to the discussion.
Thank you so much, Eran. I'm just gonna put my camera back on. That was so fantastic. Thank you so much. I've already had folks asking if they can have your slides, and I'm anticipating that there are some questions and maybe some responses to the questions that you posed. I really appreciated that visual of the frozen measure. I feel like that was I think it also helps us to challenge the idea of standardization and what we think about standardization. So how do we think about what that concept and that idea, while also thinking about not making measures that can't be flexible, that can't actually meet the needs of young people and have young people engaged in the process of creating those. So youth engagement is my space that I care a lot about it. So I'm really thrilled to hear about all of the work that you're doing. I want to open up. Maybe you could actually share your questions in the chat if you wanted, or back up on the screen. I know that.
Oh yeah, sure.
Those were great.
Let me just copy paste those those questions to the chat.
Perfect. And we also had one question about the mobilizing measurement into care guidebook, and if that would be available in French as well.
Currently, we have only an English version, but we're planning various versions of the guidebook. I'll have to consult with my co-authors, but I think it would be really helpful to have a French version. We also want to have a version not just for clinicians, but also for young people. It's another thing we're talking about. But yes, that's on our radar.
So I just wanted to check and see if anyone wants to respond to the questions which are now in the chat, or if anyone has a question for Eran, you can please put in the chat the question, just typing it. You also can use your raise hand function.
Feel free to to just speak up. Elisa can unmute you. I'm happy to have a conversation. And also just you don't have to ask me questions. I really want to hear from you on these questions I just pasted in the chat.
Okay, Jay, I'll give you the power to speak. There you go.
Can you hear me?
Yes.
Wonderful. Well, first of all, thank you, Eran. It's a wonderful talk, and so nice to be able to step back and think about the broader ripples and implications of some of what we do, right? When we're in youth services, we kind of, when we're doing day-to-day clinical practice, you just kind of go through the motions to some extent, and it's very helpful to sort of step back. My question was drawing on the idea that measurement might not just be sort of taking information or generating knowledge from people, but that it might also act, even if inadvertently, as an intervention of sorts, right? So it's not just that measurement takes things, it's that measurement creates things as well, like the practice of measurement, the process of measurement, including for young people. So if so, it might contribute to how young people in this case like define themselves, their identities, the challenges or difficulties they face, things like that. So if we accept that point, I wonder if you have any thoughts on that reflection, and whether there's anything you would want to say about the implications of that too. I'd just be curious for your thoughts. Thank you again.
Yeah, thanks, Jay. We, in fact, the entire chapter, or most of the chapter called Ethics of Measurement in the guidebook explores ways in which young people are affected simply by the experience of being measured, by the experience of having to sit down at a waiting room or at the reception, or with a clinician and having to respond to these questions like the PHQ-9. Some of these effects have long been studied, such as response burden, the fact that the questionnaire may be long, or the question may be hard to interpret, and a young person who's already distressed may find it difficult to concentrate on answering questionnaires. But it goes far, far beyond that, because we are humans, we're not desks. So when we're being asked questions, we're constantly interpreting both the text, but also our own experiences. If I get asked question after question, whether I'm feeling down, whether I have trouble sleeping, whether I have trouble concentrating, whether I have little interest or pleasure in doing things, I'm going to be focused on interpreting my own experiences through this negative lens. I'm going to be looking for problems. And I'm also going to start developing expectations from my therapy. I'm going to say, okay, the therapy is going to focus on my problems. I'm a problem that needs to be solved. Moreover, the fact that the response options are numbered gives me a sense of, even a completely false sense, but still gives me a sense of where I am relative to some imaginary other, how bad things are going for me. If I start to see that all my answers are in the very frequently, they're in the threes, I could start to worry about my situation, regardless of any. I don't have any norm to reference to, but I interpret my own situation simply by virtue of which answers I tick, and then getting a number at the end could signal to me, again, completely wrongly, that this number now describes me, now describes a fixed, an intrinsic property of me, my degree of depression, that perhaps I was just born with it. So there's so many values, so much content that's being transmitted through the experience of answering a questionnaire. And several of my colleagues, I mentioned Leah McClymans. I'm working with another colleague. Her name is Femke Truyens in Rotterdam. Are exploring these many ways that measurement intervenes on respondents. There's much more to say, but those are just kind of a few examples. You also asked about what do we need to do in order to to take all those interventions into account. In a way, my entire talk was about how we can start going forward on that. I think ethical iterations are an important first step. But there's also an organizational change I didn't go into. We have to really think hard about who creates the measures and where they work. Currently, to create a measure, you have to sit at the university, apply to CIHR, get some funds, fund some respondents, and all that time you're not working in an integrated youth service center or at a community or at a hospital or any particular context. You're not testing how the measure interacts with anyone in a given institution. You're validating a measure as if it was, a thermometer or a balance. So one consequence of responsible measurement is that needs to change. That measurements measuring instruments can only be validated in a very particular context. And when you change the context, you have to do that work again.
Thank you so much. I wanted to just comment and say that I think one of the things that some of this has come back to, and I mentioned this when Nicola had presented as well, it comes back to some of the work we were doing with stakeholders and particularly youth and family members about data and stories, and really talking about the story that you go into a service with or enter a clinical service with, but then how that shifts when you go through all of those different questionnaires, and how those different questions shape. And I was jotting down furiously, like, how different is it? How is it shaped if it's negative? How is it shaped if it's positive? What are the differences? And so I think that really does change sometimes the way that you see your own symptoms, depending on what those questions are. And I think a lot of us had how we kind of got to that work. And in those sessions, we kind of all had related to having those same experiences. It had kind of felt a bit universal that there were times where we had gone in with one set of feelings or one set of symptoms and then kind of left this appointment feeling a whole nother set of ways because of the different tools that we had come across during that experience. And then I was thinking in terms of what needs to happen for us to move forward. I think you've made a great point about thinking about that history of the measures and how the settings, like who's creating the measures, how are they being created, and maybe we need to go back and look at that. Maybe we need to be thinking about the more common measures that are being used, and maybe the way when we look at that, we bring young people into that right from the get-go to start to look at what measures have been more commonly used. We actually ask what the experience have been. A lot, it's not like there's not been many young people who've already been exposed to all these different tools and these measures. So folks have thoughts, and I don't know, I think in some ways we might just need to like go back, look at what we have and start the conversation with young people there. I think it's been very clear from just some of the folks in the series, but also just talking to a lot of people in the space working on data and measurement that we, in some cases, don't really know what works and what doesn't work and what we want and what we don't want, especially when it comes to how young people themselves feel about it. So this was so great.
Thank you. Thank you. I mean, the focus on stories makes me especially think about the importance of qualitative evidence that accompanies the quantitative evidence.
Yeah.
And this is something specifically the Femke Truyens, who I mentioned. She's a clinical psychologist and a psychotherapy researcher. She shows how the qualitative evidence we get by asking patients and respondents to think aloud as they fill out a quantitative measure, how that can sometimes completely change the meaning of those numbers, which should be obvious, right? But I think the way we've established measurement as a kind of objective evidence has made us somehow blind to the fact that it's really the stories that we care about in the clinical context. The numbers are meant to support some kind of efficient decision making in some cases, but they cannot be the whole story.
We're just over 3:01, so I do know that maybe I think there might have been some other questions that might come in, but that's okay. I will pass along to any other questions that come along, and to you in an email, and we can connect, and I can share back when I share the recording back. If anyone has any other questions or comments that you want, you can always send by email. I'm going to share in the chat right this second how you can get in touch. They didn't do that earlier.
Please do. I see there's one more question that we're out of time, but I'm happy to reply to an email. Perfect.
And you can also find us at our website. You can find us at YouTube now. We have a YouTube channel where you can watch the most recent webinar. And Eran's put his email into the chat. I'm going to put my email into the chat. And we have another webinar happening in 2 weeks. And so in 2 weeks, we'll hear from Gina Dimitropoulos and also Jason Gonzola. I might be mispronouncing Jason's last name, around measurement-based care and digital e-mental health. So you can join us. I will also share this in the chat. So thank you so much, Eran. This is great. I am happy
Lisa.
to have had this conversation.
Thanks, Jay, and everyone for.
Yeah, thank you everyone for attending, and please continue to join. I didn't share the actual registration, but that's fine. You'll get it in an email. Thank you, everybody.